Hey, good afternoon, everybody. This is Musculoskeletal System Part 2. So I don't know if you had the chance to listen to Part 1, but we talked about something called fat emboli, which is a thing that can happen with bone musculoskeletal issues. It's something you have to know and be looking out for. There's another thing that you need to kind of know that's associated with bone and joint, and it's called compartment syndrome. And I can read this to you, but I need to explain it to you. If you go down into the lower leg and you were to look at it on it like we cut it like you would cut a steak and take a look at it, there's like a lot of compartments down in there. There's bone, muscle, veins and arteries, and they're down there. And what happens is somebody goes and they have an injury, and they have it, particularly if they have a cast on. They go and they get enough pressure and it starts restricting their circulation in those muscle compartments in the extremities. And they get severe unrelenting pain that's unrelieved by narcotics. So you say to yourself, well, what am I looking for here? Because I know we can't always make a patient appear for you that has some kind of unusual thing. I can't make people sicker than they are. And so these are where some assessment skills come in. If I am wearing a cast and I come back, let's say I come back from physical therapy, and you medicate me for with whatever, and my pain is just severe and unrelenting and nothing's helping, you always have to assess anybody with a lower leg, particularly lower leg problem, for what they call the 6 Ps. Pain, pallor, paresthesia, pulselessness, paralysis, and poikilothermia. And that just means cold to the touch. So anytime someone has a cast or they have a ruled type walking boot on, I always come and I always check. When I come to check on them for like hourly safety checks, I take a look at their foot. I say, how is your pain? Tell me about your pain. I look to see if there's capillary refill. I touch the foot. I tell them to wave at me. Say, wave your toes at me. And I'm doing that because if they would get a problem underneath a cast up in one of those compartments, they could lose their leg. So anything like this is very, very serious. It's something that you have to like kind of remember. And I can tell you, they'll ask you this on a test. They'll ask you this later on exit test. And this is something you would want to be watching for down the road. And then you tend to get into this thing when you're a nurse. You say, oh, that guy, he complains all the time. He's never happy. I need you to go in there and look at a person's leg. Is there a problem with the pallor? Is there paresthesia? Can you feel a pulse? They could have a problem down there. And if you are giving them narcotics and they say the pain is getting worse, you may have a problem down there. And they actually, if you want to use your phone for something good, you go there and they actually can cut the cast open and they basically fillet the leg open to get that pressure off of the leg. So here are a couple of pictures to kind of give you some context. The one on your left that's marked picture B is where they took like a slice of a lower, an area below the knee to show you how many compartments are located down in your leg. And I guess there's like 50. This picture doesn't actually quite show that. The picture on the right is what they have to do is if you're having pressure down in there, they basically have to cut the side of your leg open to get the pressure off. If they don't, you will lose your leg. And this explains why if I have a cast or some type of tight dressing and the nurse doesn't go in there and check that lower leg for the 6 Ps, this patient could lose their leg. So this is why this is such a serious issue. So treatment and nursing management in compartment syndrome is you recognizing an immediate notification. When you see those 6 Ps change and they're not falling within the parameters that they should, you have to let someone know right away or that person is going to lose function or possibly lose their leg. If there is a cast in place, they bivalve it, like cut it open, and they may actually cut open into the skin. If it's a dressing, they may have you cut it off. It can always be replaced. This is an additional slide talking about this surgical fasciotomy where they do this incision down to the facet to get the pressure off of the leg. And they're talking about you need to elevate. Elevation is the key to preventing compartment syndrome. Toes and fingers should always be higher than the trunk of the body. Okay, so there are just some things that you should say for all musculoskeletal issues. First one, if they're taking NSAIDs for pain, we want to monitor them carefully, make sure there's no GI, gastrointestinal intolerance. They're not developing any type of bleeding ulcer or anything. We want to assess liver, kidney, central nervous system frequently. You want to watch for problems with tinnitus or hearing loss if they're on antibiotics or aspirin. And don't forget about the NSAIDs. The side effects are very serious. If there's toxicity, you would want to report that very quickly to a physician. Let's change gears just a little bit and talk about patient teaching for total hip replacement. A couple things. It is okay for them to lay on their operated side. Uh, it might hurt, but if they want to lay on the side that the operation was on, they certainly can. And for up to 3 months, they are not to cross their legs. We normally put a pillow between their legs when they roll them around. They actually have a thing called an abductor pillow and that they used to put between the legs, and now they have this abductor brace that everybody wears. And this idea is not to abduct the leg. Remember, they're going to have to cut through the hip. Everything that holds your hip joint in, they have to cut through there to get in there to repair the hip. So your hip's real easy, it could dislocate. So we watch very, very, very carefully with that, and that's why they use either the pillow or they use these new braces that they're using. It is okay to bend your hip but not be on a 90-degree angle. They usually have an elevated toilet seat. They don't want to sit in low chairs, and they need to work with their physical therapist so they can get their muscles strong and back to their original ability. So let's talk quickly about gout. Gout is a form of arthritis. It causes severe pain, swelling, redness, and tenderness. It's actually kind of a form of arthritis. It's caused by too much uric acid that crystallizes and it goes down and it settles in your joints. And I'm talking severe pain. It normally happens a lot of times in the big toe. I have seen it happen in other joints though, in the knee and the ankle. These attacks, they come in kind of suddenly, not a lot of warning. And you can control gout. They control it with these medicines that remove the uric acid. You can control it with changes to your diet. The treatment is usually, if they come in with an attack, they'll put them on NSAIDs for like 2 to 5 days. And then they have some medications. They have allopurinol, which will prevent you from having another gout attack, colchicine and probenecide, and one now have called Uloric that can treat gout, and some nursing, teaching, and management. As you guys know, it always ends up being about the teaching. We want to go diet management. We want people to kind of control their weight. They have to restrict high purine foods, and that's something like salami or head cheese or something you buy at the deli. And we want them to increase their fluids and drink plenty of water. So let's talk about osteoporosis. In always etiology and pathophys. And so this is a condition in which bones become weak, they get brittle. When you get osteoporosis, the bones become weak and brittle. Remember, your body's constantly absorbing and replacing bone tissue. And then when you get osteoporosis, the new bone creation is not keeping up with the old bone removal. And there's like not a lot of symptoms early on when you have osteoporosis. Once the bones get weakened, then you start to get symptoms like back pain, a stooped posture. They get a loss of height where they're kind of bent over, and they start to have bones that break very, very easy. There's another term on here, osteopenia, that's a condition where your bone mineral density is lower than normal, but you don't quite have osteoporosis. So I have heard those terms used interchangeably. They do not actually mean the same thing. So let's talk a little bit about how we treat and what's going on with osteoporosis. There are some risk factors. As you get older, you are more at risk. Chronic diseases make you more at risk. If you take steroids, anticonvulsants, anticoagulants, proton pump inhibitors, a drug called SSRIs or selective serotonin inhibitors. If you have just a calcium deficiency or vitamin D, you're a smoker, particularly smoking, puts you at high risk. Lots of caffeine or alcohol and a sedentary lifestyle. These all put you at heavy risk for osteoporosis. Osteoporosis actually does not have any early signs and symptoms, but as you go along through this disease progression, they start to get a height loss and kyphosis, and that's where they have the bend in their back. So that's probably a new vocab word for some of my students. And they get compression down in their spine. They actually can diagnose this with either a bone x-ray or what you probably will hear a person say they had a dual energy x-ray or a DEXA scan. It actually is just like an x-ray. You sit up and they take a picture of your hip. They take a picture of like your arm. They're looking to see if your bone looks like Swiss cheese. As you move on through the process of osteoporosis, your bones start to look like Swiss cheese, and it's very easy if you have a fall to break a hip. Goals and treatments with osteoporosis are pretty clear cut. We want to stop this bone density loss and increase bone formation and prevent them from breaking something, prevent a fracture. A lot of times estrogen replacement therapy has been used, adequate dietary and supplemental calcium and vitamin D, weight-bearing exercise like a water aerobics as a person gets older are very helpful. There is a class of drugs called biophosphonates, and something that sometimes people don't put together, students particularly don't put together, is your calcium is made in your thyroid or your parathyroid. So, and we need to check these people's parathyroid hormones. So if somebody does have a parathyroid problem, they may have osteoporosis. And sometimes people don't think back to their anatomy and physiology classes and put those two together. So let's talk about osteoarthritis. It's a type of arthritis that occurs when the tissue at the end of your bones wears down, and that's your cartilage. That cartilage is flexible, it's protective, it's what cushions everything, and when it wears down, you have bone touching bone. It happens over time. It's kind of gradual. Some common places to have osteoarthritis are your hands, your neck, your knees, your hips. And it's usually asymmetrical, meaning it's on one side. They also often call it degenerative joint disease, kind of common. And the chief symptoms. Well, there's an aching pain when people tell you they're trying to move, and anytime they have joint movement, they'll have stiffness and a lot of limitation of their mobility. The joints may look a little deformed. Sometimes you see nodules. It's actually quite a very common diagnosis. What are some treatments for osteoarthritis? Well, um, pain management comes first. It could be aspirin, which is salicylate. You guys know acetaminophen from your pharm class. NSAID, ibuprofen or naproxen. They do recommend strengthening, aerobic exercise, weight reduction if you're overweight. Try to maintain that joint function. There are some complementary and alternative therapies. Turmeric helps with a lot of the inflammation. I've heard people take this glucosamine chondroitin, which goes, I think, sells under the name Osteobiflex. If the person's joint continues to deteriorate, they do have surgical treatment, which is when they do a total joint replacement. We definitely need to talk about rheumatoid arthritis. Most nurses say RA, they just abbreviate it. RA is a chronic inflammatory disorder. It usually affects the small joints in the hands and feet. Okay? In rheumatoid arthritis, your immune system is attacking its own tissue, particularly in the hands and feet. And in some people, this starts to affect all their body systems, like their skin and their eyes. And it also goes and affects the joint linings, and it gives you something called pannus. It's like an extra layer of tissue that ends up building in there. And it's very, very painful. Okay. You also have something called ankylosis, which is when the bones actually start to look fused together. Their hands will kind of bend up and almost look like a swan. Okay. They can also get these nodules on their pleura, their heart valves, and their eyes. And since it's a disease that is the body's immune system is attacking its own tissue, then these folks are going to be on immunosuppressants, which is something to keep in mind because we've talked a lot about immunosuppression in this class. So again, for rheumatoid, signs and symptoms, they get an onset of joint pain. The joints are warm. They're usually swollen, a lot of limited motion, and this is symmetrical. It's on the hands and feet on both the left and the right side, and very limited when this person's ADLs. Usually they have adaptive equipment to eat. They need a lot of help with their morning care when you go to take care of them. So for rheumatoid arthritis, when they do the diagnosis, usually these people have a history of morning stiffness that lasts longer than 1 hour. People with osteoarthritis usually get up and get moving, and they're usually okay. And for people with rheumatoid, it's usually in 3 or more joints. It's lasted longer than 6 weeks. So they do have a blood test for rheumatoid. It's actually called the rheumatoid factor. The only time you ever hear any doctor order it is if he suspects rheumatoid. The other test that you'll see is something called a C-reactive protein and the ESR, the erythrocyte sedimentation rate. These aren't ones that I normally have you memorize. They're not ones that I normally have memorized in my lifetime career as a nurse. But they're ones, if you hear them ordered, they're suspicious that they have rheumatoid. The other thing is they do x-rays to kind of confirm this cartilage destruction and the bone deformities that onset with rheumatoid. So treatment for RA. One of the first things that you often see these patients receive is the drug called methotrexate. Methotrexate actually comes up under chemotherapy when you do like reading in a pharm book, but it also comes up 4RA. Okay, because of what it does as an immunosuppressant. Another drug, an example is one called Humira. And Humira is a class of drugs that have come out that are all immunosuppressants that are given for RA. They also can be given for other diseases that are where the body is attacking itself, for instance, like ulcerative colitis or Crohn's. So you probably can put to, as you learn more and more about med-surg, you'll see drugs in that particular class come up. The other drugs that they can take are NSAIDs, which I know you know is highlighted a lot in pharmacology. Steroids, they can use heating pads. I've seen them exercise the joints, and I have seen people come in for joint replacement surgery. The slide here defines Paget's disease as abnormally weak bones, but to be specific with you, it's a disease of the bone that interferes with your body's normal recycling process. So the process where the new bone gradually replaces the old bone, it doesn't work right. So over time, those bones become fragile, they're misshapen. It can affect the pelvis, skull, spine, legs. The risk tends to increase with age. One of the signs and symptoms is always severe pain. And on reasons unknown, I guess this disease is not very common in the U.S. anymore and seems to be less severe. A lot of people get a lot of broken bones when people come in. They find out that they have this disease. One of the they diagnose it. They do a urine collection. They're looking for some waste material from your bones that go out through your urine. The other thing is they treat this with bisphosphonates, which are the medications we also give for osteoporosis. And those are one you always have to learn in pharmacology. Are very, very common. All of the textbooks that we're currently using and in ATI and some of the online modules that people use in nursing school discuss bone tumors. Anytime you see the term bone cancer or bone tumor, it's a bone cancer. Usually begins in the cells that form your bones. One of the most common terms you see here is osteosarcoma. It most often occurs in the long bones in your arms and legs. Symptoms would then be localized bone pain and swelling, and that can be benign or malignant when it sets in. Usually bone cancer is more on the malignant side, and there's usually a primary side and a secondary issue that goes on with this. So those are all terms that come up when we talked about oncology, and you should know those vocabulary terms already. Some of the main signs and symptoms with bone tumors is just pain, severe pain. The bones and the legs are warm and they'll be swelling. And they do diagnosis with either a bone scan, x-ray, they may have to do a biopsy, and treatment usually involves surgery, radiation, and or chemotherapy. Amputation. Lower limb amputations are usually related to like peripheral vascular disease, diabetes, and sometimes there's a resultant gangrene. It can be related to trauma, maybe malignancy, some type of congenital defect, and a military injury from shrapnel. An upper extremity amputation usually are brought by crushing injuries or blows or some type of burn or malignancy or possibly infection. Some nursing information for you. If there is an accidental amputation, we would rinse the detached body part to get any visible debris, wrap that part in a cloth and put it in a sealed bag in a dry container, and you want to put that on ice. Don't let the part get wet or freeze if you put it in on ice, because sometimes they have been able to reattach like a finger. I've seen them reattach someone's finger, so that's what I'm familiar. They had put the finger on ice, the patient came in, they were able to reattach. Some common issues if someone does have an amputation and you are taking care of them. One of the big issues we watch for is possible hemorrhaging from that site, that in a surgical site. That edema, we have to watch it on the residual limb. We have to watch it for edema. They usually have it elevated. We normally monitor the area there, and we check those 6 P's down on that amputated area. Okay, remember the pulse, pallor. And we take care of the dressing. And a lot of these people get something called phantom limb sensations. And if you think about this, the nerve doesn't know the leg is gone. It still feels the leg, it still sends it back. And sometimes patients who have that phantom limb sensation, they need to know that it's okay to have it, and they need to know it's okay to ask for pain med. They really are having pain. If a patient puts his collar on and says, I'm having pain in my left leg, and their leg's been amputated, you have a moment to run through your head like you don't have a left leg. They are actually getting, the nerves are sending back a message from the leg, even though the leg is not there. Some additional postoperative care when a patient's had an amputation. Below the knee amputation is easier for people to begin walking and weight bearing than above the knee. Abduction contractures, we do sometimes roll them on their belly, which is really unusual. We don't want to get that stump contracted. We want to make sure that we are working to prevent that. And they do have a new center of gravity, so they have to really, really work for that. We have to teach them stump care and how to do weight bearing and exercise. And they normally go to some type of rehab setting, so they can go back to doing their own ADLs. There's a lot of resources out in the community, and it's always nice to have someone. If there's been someone who's been through the same thing, that's always a good way to try to encourage someone to continue to get back to some type of normal life.